of injury and the mechanism of injury during terrorist attack, and is really something very interesting. But not only interesting, I will tell you that is something that will make a better care for our patient if we are able to classify better even people with this kind of injury. Thank you, Yoram.
Thank you, Luca, and thank the organization for the invitation to this beautiful sitting. I would like to take you now.
Крайняя кнопка справа. Крайняя справа.
Yes, okay. I would like to take you now from the bench to the trench in regard to bomb explosion and try to take you from the very beginning of the detonation to what we are supposed to do is to provide medical care. Terror activity may result in various fashions. It can result from stabbing, shooting, explosion, as you see here. It can result in single wounding, in mass casualty incidents, and what we call back in Israel a mega terror incidents like what happened in 9/11. It can result in single organ injury, in multi-organ injury, and in something that we define as a multidimensional injury. And this can be from conventional and from non-conventional weaponry. And one needs to remember that nowadays we are very much afraid that our terrorists will start to use non-conventional weaponry for which most of the hospitals are not prepared. I'm going to talk now on mass casualty incidents only that result in this devastating picture, as you see here. This is a bomb explosion in the center of Tel Aviv that resulted in the deaths of about 20 young injured. So I'm going to talk about explosion. I'm going to talk about explosion that result in this devastating picture, and you should remember that the terrorists usually detonate the bomb in very crowded areas with a lot of people inside, and this is in order to increase deaths and wounding. This is another place back from our city of Haifa, and a bomb exploded in the middle of a cafe shop that resulted in about 12 deaths and about 25 injured people. Doesn't work? Okay. So we're going to talk about multi-organ injury, and this is an example of multi-organ injury. You see limb injury, chest injury, gluteal injury, head injury, all in the same patient. And I'm going to allude of what we call the multidimensional injury, and the multidimensional injury pattern in bomb explosion actually, sorry, this doesn't work properly. Yeah. Okay, so what you see here in the multidimensional injury pattern, you see head injury, chest injury, all from burn, and multiple shrapnel injury. Those are two patterns of mechanism resulting from bomb explosion. And I'm going to talk about conventional terror attacks. And this is another picture of conventional terror attack, which is a bomb that exploded in a very crowded area in the mid-city of Jerusalem. I'm going to allude just a little bit on the non-conventional bomb explosion, which we are now trying to get into the issue by preparing our hospital toward this kind of event. And I can tell you from my experience, none of the hospital is ready for the dirty bomb that all the newspapers are talking about lately. So one needs to remember that while using bomb as a weaponry by the terrorists, the people who are affected by bomb explosion are usually the young patient. You see here about 70% are between the age of 15 and 45. Again, you see here a bomb exploded in a pub in Jerusalem. Many young people who are coming to these areas are injured by the bomb explosion, many casualties, and high rate of mortality. As you see here, the ISS of patients inflicted by bomb explosion is higher than in non-terror events like stabbing, like car accident, or domestic violence. When we are talking about bomb explosion in act of terrorism, the ISS, the injury severity score of the patient is higher than the conventional trauma than we treat. But now remember that the ISS take into account only 3 body regions. And in the patients that we treat in bomb explosion with a multi-dimensional injury pattern, more than 3 injury regions are injured. Therefore, the number, the ISS, does not reflect the intensity and severity of the patient complex of injury. As you see here, a patient with a major femoral artery vascular injury, evisceration of his gut through a major abdominal wall injury, and this patient had also a chest injury and a head injury. So we're talking about multi-compartmental injury in patient with bomb explosion. And as you see here, depicted in this slide, the patient with more than 4 body regions injured is higher in explosion than in all other conventional trauma that we treat in our hospital. This is another picture explaining what I'm talking about. A patient coming in with an amputation of the head, multiple shrapnels in the chest, head injury, and an eye injury. This is actually what we discussed in our bomb explosion victims. The patients that we treat need more surgeries, and as you see here, that about 40%, 45% of our patients injured by explosion need surgery. This is opposed to about 30 or 35% of the non-trauma, non-terror-related injuries that we treat every day in our hospital, and not just in Israel. Our patients need more intensive care unit treatment, and as you see depicted here, more than 20% of the patients admitted to the hospital from bomb explosion need hospitalization in the intensive care unit. This is opposed to about 6% of all other trauma that we treat. The hospital stay of our patient admitted for after bomb explosion is higher and longer among patients who are coming from injury induced by bomb than all other traumas that we treat. Not only body-inflicted injuries, but also on the cellular level, there is a difference between the trauma, the conventional trauma patient, and the bomb explosion trauma victims that we treat. As you see here, there are thromboxane, other prostacyclins, and other leukotrienes, interleukins are all higher in the trauma patient that is inflicted by bomb explosion than all other trauma mechanisms. So we are talking about a unique pattern of injury. Young patient, the injury severity is higher, number of body region is higher, they need more surgical intervention, their hospital stay is longer, they need more ICU stay, and the mortality is higher. So we are talking on the multi-dimensional injury pattern of bomb explosion victim, which is actually diverse mechanism of injury. As you see here, a patient who had amputation and third-degree burn on the amputated limb. We talk on diverse mechanism of injury, and I'm going to allude about this issue later. And as I mentioned before, the multi-compartmental injuries. In order to treat a bomb explosion victim, one needs to understand and have a knowledge on 4 components in order to better management of the patient. One is to understand the physics of detonation and explosion. The other is to have basic knowledge on ballistics, very good knowledge in triage, and of course, basics in medical care of bomb explosion patient. So let's go to the detonation. The detonation, the blast, is a wave of air under very high pressure that emanates radially, as you see here, from the explosive source at the speed of the sound and is followed by a wave of air under negative pressure. As you see here depicted in this illustration, you see the center of the explosion and the wave that goes radially from the center of the explosion. If you take the component of the blast is actually built up by what we call the blast front. The blast front, which is only 3 to 4 millimeters thick, results in the peak overpressure of the blast, and this is followed by the blast wind. Those components of the explosion are very important to understand the clinical patterns of this type of mechanism that results in the injuries that we see. This is the illustration of the overpressure, as you see here. This is a bomb detonation. There is a very high overpressure resulting in the site of the explosion that then radially spreads surrounding the explosion, and then within milliseconds, a negative pressure results in the site of the detonation. This brings the overpressure and then the negative pressure that sucks in everything back to the site of the explosion. So if we take about 25 kilograms of TNT, this will result in 150 psi. This will durate only 2 milliseconds, and the blast wave will travel in a speed of 3,000 to 8,000 meters per second. This is the what we call the shock front, only the 3 to 4 millimeters thick front of the explosion. More explosive will be added to the bomb. The longer duration of the shock front will emerge. Okay, so we are talking about patterns of injury that are induced by the bomb explosion. Those are the primary blast injuries, secondary blast injuries, tertiary blast injuries, and what is called the quaternary blast injuries. Let's go to the primary blast effect of the bomb explosion. This is induced by the blast wave itself that passes through the victim. You should remember that the human body is very resistant to blast wave. Tissue respond according to differential density of them, and solid and fluid, solid like the liver or like the spleen, or fluid-filled organs like the blood vessels are rarely damaged by blast. But air-containing organs like the lung or ears are suffer more from the blast. So if you go back to this bomb explosion and we go to the blast front, okay, this is a resultant of the injury patterns that we see in what we call the primary blast effect. Eardrum perforation, blast lung and multiple pneumothoraces, and perforation of hollow abdominal viscera. This is a nice picture that depict perforation of the eardrum, and as you see here, in 50 to 50 psi, about 50% of the patient will suffer eardrum perforation. Now, this was in the past a hallmark to the exposure of the victim to the blast. So we used to examine eardrums of all patients who came into the emergency room after blast explosion. We now know that it's not linear. We know that in young patient with a very elastic eardrum and in young patient with cerumen in the canal, there will be no eardrum perforation, although the patients suffer blast injury. Nowadays, the way that we detect patients who were exposed to blast is by looking on the soft palate. Soft palate that suffer blast injury show petechia, very small petechia, that is our indication that the patient suffer blast injury. This is a picture depicting the blast lung in 50 to 100 psi. About 50% of the patient will suffer this type of injury. The effect of the blast on the human body results from the passage of the blast air through the human body. This called two mechanisms. One is a stress wave, and the other is the shearing force or shear wave. The stress wave results in the peak velocity, and the shearing force results from the amplitude of the explosion. Now, if you take a blast that passes through the lung, it passes and hits a blood vessel filled with blood. This bounces the blast away and results in an area of overpressure. So if the blast goes through the lung, hits the heart, it will increase its velocity, therefore increase the damage to the other part of the lung that is filled with air. In regard to the abdominal organs, bowel perforation, although a hallmark of blast injury, are very rare. We see it more in a submerged patient, a bomb exploding in the water because the water increases the blast wave, okay? Remember that this patient with bowel perforation may present with clinical signs of bowel injury very late after the injury occurred, and this is presumably due to mucin dissection between the layer of the wall, and solid organs like the liver, the spleen, are rarely injured in blast wave injury. But you need to remember that ultrasound and, of course, tomography needs to be used very carefully in order to detect this type of injury, because some of them will have very late presentation. So you'll have a patient with a blast injury to the bowel. He looks fine, his abdomen is soft, non-tender, his ultrasound is normal, no fluid, and then within 12 hours he will return with diffuse peritonitis, because this is a process of evolution of the injury. Therefore, if you suspect an injury, you need to use something else than ultrasound and tomography, or to repeat the ultrasound within 12 hours, or to go and recheck the patient again and again, continuity of care of the team who examined him in the emergency department. This is a very nice depicting of a blast injury. Those are not shrapnel injury. This is a blast injury on the abdominal wall. You see multiple petechiae, no shrapnel, and the patient suffered major abdominal injury. This is the type of injuries that we see later on. You see hematoma. The color are not fine, but you see hematoma in the abdomen, in the wall of the intestine. Some of this hematoma further on results in the perforation that we see later on in the course of the patient in the hospital. So there are some what we call clinical tips, as Forrester mentioned before, for the abdominal injuries from the primary blast mechanism. First of all, ultrasound and tomography. There is a plea of concern in regard to this. We brought back DPL, diagnostic peritoneal lavage tray, to the emergency department to use in mass casualty incidents in order to detect patients who you suspect that they have injury to the bowel, so we lavage the abdomen. We repeat the ultrasound 2-3 times, even more, in patients who are admitted to the hospital. And of course, we now use extensively laparoscopy in order to detect intra-abdominal injuries. So the putative mechanism of the blast wave are spalling effect. If you take an fluid air-filled organ like the cecum, for example, and you pass a blast through it, it will cause sparkles. These sparkles, as you see here, like sparkling water, results in very high velocity sparklings that hit the bowel wall and therefore result in the type of injuries that we see. The other mechanism that we see is what is called the acceleration, deceleration. This is the most important mechanism that we see. You see the bowel from the blast goes forward and then by its mesentery pushed backward. This will cause injury to the bowel, and what is called the explosion, the implosion effect. When a blast goes through an air-filled organ, the bubble of air that fills this organ reduces its size and then increases its size 2 or 3 times to the basic size of the bubble air, like in the lung. This double and 3 times increase in the size, in the diameter of the bubble, results in the type of injury that we see in the lung. This is called implosion. Other organs that are affected by the primary blast injury mechanism are the CNS, the central nervous system. Some of the patients that we see are dead in the scene without any obvious injury. Those patients most probably have the injury, the blast injury to the brain. One needs to remember that brain injury also have lucid intervals, so you can get a patient who speaks to you in the emergency department, but then within 2-3 hours loses his consciousness because of head injuries that was not detected. This is a result of the primary blast injury. As you see here, abrasion and lens dislocation, not from shrapnels, from the blast wave itself, and coronary air emboli that result like an ischemic attack. And some of these patients with coronary air emboli also will be found at the scene dead without any obvious external injury from the blast itself. There are common places from bomb explosion in act of terrorism, and those are the open space detonation, buses, which we call the ultra-confined spaces, and of course the closed spaces. As a command director of the event or the triage officer, you need to get from the very beginning of the event the exact location and the exact story of what happened at the scene, because there are differences of type of injury, mortality, and morbidity in which are we in each one of these places of bomb explosion. We know that victims of outdoor explosion suffer a non-critical injury and therefore low mortality in the immediate phase and low mortality at the late phase. If we talk about the confined or ultra-confined spaces like buses, you see that the mortality in bus explosion is higher. The ISS of the patient is much the same, but this is a result of early deaths at the scene of patients who suffer bus explosion. Multiple injuries are less in bus explosion because the mortality is higher, so less patients actually reach the hospital. You see that patients who reach the OR are lower than confined spaces, and the ICU is even lower. And this is the result of high mortality rate at the scene in confined and ultra-confined spaces like buses. So what happens in confined space explosion? As you see here, If we detonate a bomb, the blast hits the surrounding and causes overpressure. But because this is a confined space like this hole, the overpressure is very low. So it builds up a pressure, a high pressure, resulting in high mortality, but the overall overpressure is lower than in what happens in the bus. For example, if a bomb detonates in a bus, needs to be detonated now. Sorry. Okay. You see that the overpressure builds up very early after the detonation. So the overall overpressure of the detonation is very high as opposed to confined space and, of course, open space. And therefore, the mortality in bus explosion, which is very common in our region, is very high. Let's go to what is called the secondary blast injuries. Secondary blast injuries are the results of the additive of what the terrorists add to the TNT. Usually they use spherical balls, nails, and other sharp particles embedded or covering the TNT. The TNT can be either from military origin, homemade, like we see a lot in our place, or commercial. This is built up like a vest on the terrorist, and he detonates this in the center of the crowded area. So again, you go to the explosion, you see that the explosion results in a propelled object from the explosion center. This propelled object result in major and devastating injuries to the patient in the very near perimeter of the explosion. This is usually what is left from the terrorist itself, because he actually received a lot of overpressure in his territory of the explosion, but all the other will suffer from this, as you see here, shrapnel that is propelled by the blast wave from the very near perimeter of the explosion to the surrounding. And as you see here, depicted in this picture, those pellets enter the body and result in major and devastating injury to any tissue that this actually affect. Those propelled obstacles are actually, they have the same, what we are calling flying ballistics of any other rifle or pistol or gun bullets. Okay, they act the same on the tissue, and if you shoot them in a gel, like we do in forensic medicine, they have the same pattern of local tissue damage. But the difference is that in mass casualty, in bomb explosion, we see multiple penetration, multiple saturation of the body that result in major and devastating injury. As you see here, like in this helmet, usually when we talk about bullets, the entrance wound and the exit wounds are different, especially if you know the velocity and you know the distance. When we talk about pellets, usually the pellet's entrance wound is larger than the exit wound. And the reason for it is that the impact of the pellets actually releases its energy in the entrance of the entrance and not in the exit. It loses the velocity while propelling within the human tissue. Therefore, the entrance wound of a pellet is usually larger than the exit wound. This effect, the ballistic effect, results in what we call peppering, as you see here, peppering of the face, multiple shrapnel penetration, multi-saturation of the human body with pellets. This results also in fragmentation of the casing of the bomb and debris and masonry that is energized by the wave of the moving air, and it depends on the charge and the velocity of those missiles. In the patient who arrive into the hospital with multiple penetration, as you see here, we see major vascular injury, usually the results of those pellets and nails, with major arterial and arterial injuries and other the tissue surrounding this injury with devastating injuries. That is a big problem while talking about covering this area after repairing them. You see here other picture of patient who suffered penetration of pellets. You see this patient with pellets entering his shoulder. This was lodged actually in the shoulder, and was removed by scopy in order to improve this patient's shoulder movement. This is another patient who came in. This is a very interesting case. This is a young 16-year-old patient who came in with bleeding in his neck and bleeding from his popliteal artery, and actually arrested in the emergency room. What we did, first of all, we resuscitated him. We put pressure on the bleeding because this was in the back of the neck, and we put a tourniquet on his leg. He was resuscitated, rushed to the angio suite, and this was a vertebral injury that was embolized. The patient survived after the popliteal artery was repaired and went home after he arrived in arrest to the emergency department after 5 days. Okay? So you need to know this type of injury in order to treat your patient. Another very nice depicting patient of SFA injury from a nail. The patient came in with a very small hole in his skin, but he didn't have any distal pulses, therefore he had angio, and the angio showed this type of injury. This was repaired, the patient was discharged. This is another patient. You see here, this is a stable patient who came in to the hospital after a bomb explosion. You see a very large hematoma surrounding the aorta. Eventually, what was found is that he had a pellet injury going through and through the aorta. The patient was stable because of the hematoma that was contained, was operated, those 2 holes were repaired, and went home after 5 days. This is a young lady who came in comatose, and you see this spherical ball launched in the 4th ventricle of her head. This was removed, and she survived the injury. So those are very typical injuries of the spherical ball, the secondary pattern of bomb explosion. So the clinical tips to this multiple penetration are clinical judgment, using of focused abdominal sonography in order to detect intra-abdominal fluid collection, DPL, extensively use of DPL in those type of injuries, laparoscopy, thoracoscopy, and we use CT scan only late in the event, because the first patients who are rushed to the CT scan are only patients with head injury. So the CT scan is occupied by patients with head injury, and the CT scan is not used to detect or evaluate abdominal injury initially. We can use it later, we can use it during the night, but not initially while we treat the patient. Okay, other clinical issues that are very important in dealing with what we call secondary blast mechanism are the multiple penetration. Is the patient stable or unstable? Is the patient comatose or non-comatose? Does the patient need surgery now, or can we delay surgery for later on? Because in the beginning, we don't know how many patients are going to reach the hospital. We don't know how many patients will need surgery. Therefore, the emergency surgeries are done only for life-threatening injuries or limb-threatening injuries, but not for debridement of wounds, bone stabilization, and so on and so forth. And the availability of diagnostic modalities, of course, initially when the event starts, is very poor. Let's talk about the tertiary blast injuries. Those are induced by the blast wing that follows the blast front. And this actually may result in the acceleration of the victims against a stationary object. The longer the duration and the higher the amplitude of the explosion, this will result in higher tertiary wounding potential. Usually the tertiary blast injury is responsible for what we call total body destruction and amputation of limb. I'll show you some slides. It can cause fracture of the bone and then avulsion of the limb itself. Again, this is the explosion, and we are talking about the injury that results from the blast wind, not from the blast front, but the blast wind that follows later on. This is a picture of a patient who suffered amputation from the blast wind, not from shrapnels, from blast wind. One, in the past, we used to saw that patients who suffer major amputation do not survive. We now know that patients with major amputation who reach the hospital alive they survive. If you treat them correctly, they will survive. So major amputation in nowadays is not an indicator for bad outcome of the patient. Those are other pictures depicting amputation, not from shrapnels, not from the explosion, but from the blast wind. As you see here, a limb that was avulsed from the hand just from the blast wind. So in order to complete an amputation or to do an amputation in this type of mass casualty incidents, you need a team approach in order to avoid unnecessary amputation. We usually do guillotine amputation, and we don't fashion the amputee. We do a stepwise approach in those patients, and of course, we try to save life and not limbs. Although we have few incidents in our back of our mind of patients who the team tried to save the limb, and the patient didn't survive, because saving a limb with blast injury, with devastating soft tissue injuries and devastating vascular injury results in very long procedure, and the patient get hypothermic. People are not taking care of the other injuries, therefore mortality is very high. So this is why one needs to be very familiar with this type of injury. One needs to be very assertive with the vascular surgeon, the trauma surgeon, the orthopedic surgeon, in order to say, stop the procedure, take the patient to the intensive care, and bring him later on to complete surgery. What about the quaternary blast injury? This is a result of the thermal effect. Burn result from the ignition of flammable materials. The center of the explosion can reach 7,000 degrees, and therefore local fires starts, especially the injured who are very close to the bomb explosion itself will suffer burn, and the high temperature of the explosion can lead to what we call heat inhalation injury, which is very difficult. So again, explosion, you see the very near perimeter, which is ignite. The temperature reaches very high temperatures in the center of the explosion, and those are two examples. You see a patient who faced the explosion from far distance. This is called flash burn. Those are first or second degree burns, usually do not need any treatment, but patients who were very near the center of the explosion suffer major burns. Therefore, the clinical tips that we use to treat those patients are very early sclerotomies, but no major surgery initially. The patients are treated. No?
We are a bit late, Yoran.
5 minutes.
Okay.
Okay. So those are the clinical tips that we use
Очень
for.
интересное сообщение, ну, может быть, 5 минут еще, да? Окей?
5 minutes.
5 minutes. Okay.
So this sums up the pattern of injuries that is induced by the explosion, and then we go to what we call, back in Israel, the quinary blast injuries. We identified in some of the patients who came into the hospital a new pattern of blast injury. Those patients were very hyperdynamic. This hyperdynamic state followed immediately after the explosion with fever, high rate tachycardia, hypotension, leukocytosis. Some of them experienced cardiac arrest without any obvious external injury. And what we assume is that this is the result of the fertilizer that some of the terrorists use as a detonation material. The fertilizer that actually induced nitric oxide, and the inhaled nitric oxide call this a hyperdynamic state. So to sum up, the blast injury pattern, we are talking about the primary blast injury, the secondary blast injury, tertiary blast injury, quaternary blast injury, and the quinary blast injury. All together, they build up what we call the multiple dimensional injury. So the clinical tip for the triage of those patients are that you need to triage the patient to those who need immediate care and those who don't need immediate care, as was mentioned before. Surgical intervention is also sub-triage into 2 or 3 phases: immediate OR for life-threatening injuries or limb-threatening injuries. Phase 2, relative hold for patients who have an absolute indication for surgery, but they don't need it now for life-threatening injury. And the selective management surgeries that are usually done during the days after the injury, debridement, reoperation, second loop laparotomies to those patients. I won't go over the management of the logistical management of mass casualty incidents, but one needs to remember that the one who concentrates the entire management of the mass casualty is what we call the command physician. In my hospital, it's a surgeon, and if it results during the night, the chief resident from surgery will take care of the patient until other people are coming from home. And the triage officer is also somebody from the surgical department who is familiar with this type of injury, because we know that over triage and under triage in mass casualty injuries is very high. Therefore, you need knowledgeable people in this type of injury in order to triage patients correctly to the right place and to treat them correctly. Thank you very much.